estimated 2 million Americans experience traumatic brain injuries each year. Such injuries occur every 15 seconds. While thousands die each year from their injuries, millions more are part of a silent epidemic. These injuries are internal and usually don't show on the outside. Brain injury has deep, tragic, and profound implications for the injured and their families and friends. It's common for survivors of brain injury to lose their jobs, homes, become bankrupt, and fall out of relationships with loved ones. A brain injury can happen to you or me at any time. Please listen carefully to the information in this program in case this sort of tragedy strikes you or a member of your family. Today's speaker, Dr. Jerome Stenehjem, knows from firsthand experience that cognitive and physical impairments resulting in lifelong disabilities are frequent companions of brain trauma. However, new technologies offer hope. This interview focuses on effective current rehabilitation technology and technology that's emerging in the future. It is a pleasure to welcome today's speaker to this brain injury speaker series. Dr. Jerome Stenehjem is a graduate of the University of Utah Medical School and a specialist in physical medicine. He has treated people with brain injuries for about 20 years. He supervises catastrophic rehabilitation in a real-world environment at Sharp Rehab Center in San Diego. Sharp is a 40-bed, state-of-the-art facility and offers comprehensive inpatient and outpatient services to help patients return to productivity at home and in the community. Dr. Stenehjem is also a clinical instructor in the School of Medicine at UCSD. Please join me in welcoming Dr. Stenehjem. Let's begin by defining terms. You're a physiatrist. What is that?
Well, a physiatrist is a physician, a medical doctor who concentrates their practice in the area of expertise serving individuals with disability. And that includes individuals with brain injuries as well as spinal cord injury or people who have had strokes, and also people with chronic pain conditions, low back conditions and whatnot. So we're sort of the physicians for the disabled population.
Among the patients you treat, how common is brain injury?
Well, brain injury is treatment of brain injury is a significant part of a physiatrist's activity, and probably about a third of my work is devoted towards individuals with brain injuries. Of course, brain injury is also a fairly common problem in the community, or has a fairly high occurrence rate even in the community. Several million individuals surviving in the U.S. with brain injury, and in San Diego, several thousand individuals actually with brain injuries that are surviving, and they have special needs.
What are some of the special needs? What sort of formidable disabilities come along with brain injury?
Well, of course, the brain is managing a lot of important functions. The obvious one is cognition, and so thinking may be altered or impaired following a brain injury. There may also be effects on one's movement or motor function. There can also be effects on bowel and bladder function. So it can cause some very pervasive problems for an individual. We luckily do have some interventions we can use to help all of those problems, but it can have very far-reaching effects.
What sorts of things do you say to families who have a family member with a new brain injury?
I think probably the hardest part for families initially is that they're in a state of shock. They know their loved one is severely injured, and I think even the processing of all of that information is very, very difficult. So we do provide a lot of supportive care. Oftentimes we have to wait until they come with the questions that they want to have answered. I think that too much information early on is almost too difficult for them to process.
Sure. At what point do you become involved? Obviously, the person with a brain injury will be in the trauma center to begin with, and then rehabilitation starts at what point?
We tend to be consulted fairly early in the case. An individual with a brain injury, while they're still in the intensive care unit, sometimes days into their care, will need the help of a physiatrist, and our area of focus tends to be on preventing additional disability at that particular stage early on, preventing skin problems, preventing contractures that would limit the movement of a joint later on.
What if there is such a thing as a typical brain injury, which there probably isn't, but if you were to generalize, what sorts of interventions are standard in rehabilitation? What's been going on in the last 15 or 20 years that is just sort of like standard practice to help rehabilitate someone who has experienced brain injury?
Right. Well, the rehabilitation process, I think that the best term to apply to rehabilitation is that it's a learning environment or learning process. And I'll hear patients talk about the fact that they've had to relearn so many things. And many times the matrix for these functions or activities are still in the brain, but they can't access them. And we will assist them in doing that. So we will create an environment for an individual which makes it easier for them to begin doing some very basic functions. We may set them up so that it's easier for them to pick up a washcloth and wash their face, or we may assist their arms in terms of moving through a very basic maneuver like that. And we'll find after a number of repetitions that pretty soon they're getting better at it and they're able to do it more on their own. Where an individual can't be rehabilitated is if there is no what we call carryover, if there's no actual learning going on. That rarely happens. Almost everyone has some capacity to learn, even if it's not on a cognitive level. So we'll go through a process of maybe very rudimentary aspects of mobility, first getting some standing balance, and then taking some assisted steps, and then kind of progressing towards a higher level of independence. So we will shape behaviors and we'll shape movements in a rehabilitation setting. I'm inclined also to kind of look at the cognitive function, and for a patient who is perhaps too agitated or too distractible to be able to benefit from the interventions, they may benefit from a medication that will just calm them down a little bit so they can actually stay focused. Other individuals may be too somnolent, and a medication may help them have a higher level of alertness so that they can actually interact and benefit from the therapies.
This sounds very labor intensive and very specific to each individual.
That's exactly right. It is very labor intensive, and we have at any given time up to a dozen members on the rehab team, each kind of taking an area which is their area of specialization, and at the same time acting in an interdisciplinary fashion so that what the speech therapist does augments what the occupational therapist does. And obviously we don't want to work in opposing fashion, but rehabilitation does take many, many hours. And it can be a very lengthy process as well.
Will you talk a little bit about the place of repetition and rehearsal in working with brain injury survivors?
There's been a lot of interesting work done, say in the area of movement. We want to create a better movement. So a person has some weakness or paralysis, say, in their arm, and we want them to regain more normal function. So we may have an individual who we will assist in a very crude movement, and they may be required to repeat that over and over again, many times, hundreds of times. It's a little bit of a dichotomy, though, because we also know that the brain starts learning new things with even just a few repetitions. It's a very interesting area. So with the right types of movements, even a few repetitions at times can be effective in shaping a better response.
Sure. This discussion raises the question of whether there's any sort of debate in your field about whether the goal of rehabilitation is to restore function or whether the goal is adaptive.
We have traditionally had to focus a lot on adaptation. So if an individual has a paralyzed arm, then we may be inclined to teach them to tie their shoelaces with their good hand. So they learn how to do a one-handed shoelace. And now they may be independent with donning their shoes. But unfortunately, we have not restored function in the paralyzed arm. Because of some of the pressures in terms of using our resources to get people out of the hospital more quickly, to get them into less expensive levels of care, we have had to do a lot of adaptive techniques. adapting them to their impairment rather than restoring them to normal function. And I think that it raises the question as to whether or not we should be doing more of the restorative types of care. Now, if we have the problem of, if we have a limited amount of time and a limited amount of money, we may have to first teach adaptation and go back then and work more on restoration. Unfortunately, adaptation may eliminate the drive to restore. So if the individual can now tie their shoes with one hand, why do they need to get the other hand moving and functioning? So it's an area that's you know, has potential issues for us as a society and a culture, and you know, where are we going to spend our dollars in healthcare?
What new therapies are available that perhaps we're not particularly familiar about in the, you know, in the general press, but rehab strategies that are emerging and that will become commonplace in the next 10 or 15 years? Do some come to assisted movement therapy, for example?
Stanford and MIT teamed up, and they took an industrial robot and they used it to assist the movement of a paralyzed limb. So if the individual had any residual movement at all, the robot would assist that movement, and they could now move their hand from the tabletop up to their mouth. And in fact, if the individual had no ability, the robot could do almost all of it. And they put some patients through some trials with this assistive robot and found that indeed they did seem to improve more quickly than individuals who did not go through this type of assistive therapy. And that's opening up a new area of research for us. We've been inclined to do that in the past, even with our own therapists, where they will do what's called hand-over-hand assistance. The advantage of the robot is it can do hundreds of these types of movements without the robot itself becoming fatigued, and it could potentially act as an augmentative therapist to be able to deliver more of these types of therapies to individuals.
What about computer technologies to enhance cognitive functioning?
You know, we think of a computer as being a thinking device, but it's a really very rudimentary thinking device compared to what the human brain does. Where we want to go with this ultimately is we want the computer to be able to monitor what the person is doing and to change its paradigm based on what the person is doing. We don't currently have the interfaces that allow us to do that, but I think we will see more of that in the future.
One therapy that we read about sometimes in the news is constraint movement therapy. Do I have that term right?
Yes, constraint-induced movement therapy is one of those things that's kind of come up in the last few years. It's looked fairly exciting, and this is really not a new technology, it's really an innovation. And I say that because you really only need probably two pieces of leather, one to tie up the individual's good extremity and the other piece of leather to whip them to make them do things. And I of course say that in jest, but the reality is if people have some movement in an affected extremity, a paralyzed extremity, and you restrain the good extremity and you make them use the paralyzed extremity, they will get better. And individuals who have been paralyzed for many years, 12 years, 15 years, when they're put through this paradigm, end up showing remarkable recovery and remarkable improvement. And it demonstrates the latent ability in many people that have paralysis from brain injury. But I think this is a potentially helpful area, and it gets back to this issue of restorative versus adaptive. This is a restorative technique. And it's about 6 hours a day of therapy, but it only takes 2 weeks, and then ongoing activities after that.
In 2 weeks' time, it can have a real noticeable impact.
Yes, and I think
that's really amazing.
It is amazing, yeah. And I think what it tells us is that a couple of things. One is that if there is latent function there, it'll be revealed fairly quickly. And these patients, I will say, they have some movement. The arm is not completely paralyzed, and so you have to have some, at this stage, some basis to start with, some function to start with. But I think that some of the cases are absolutely dramatic. They're almost mind-boggling to believe that a person who could barely raise their wrist up can reach out and pick up a soft drink and drink from it after 2 weeks.
Memory is a big issue. Loss of memory, particularly loss of short-term memory, is a big issue with brain injury survivors. Are there pharmaceutical interventions that are new or coming on the market?
Our brain uses chemicals to send information across synapses, and we know when people are very depressed that a lot of cognitive functions wind down, even without a brain injury. We'll see a loss in memory and a lack of initiation and fatigue and many things that we may see in someone with a more global brain injury. We know we can use medications to affect that and to improve a person's function. So I like to look at an individual with a brain injury and in terms of their memory, but also in terms of their overall function, and see whether or not there's anything we can do to kind of allow them to have the best chemical environment really for their brain to function in.
What about the place of exercise and diet and a positive attitude in rehabilitation?
Yes. You know, early on in rehabilitation, we're worrying about people surviving, and we're worried about them not getting a pneumonia from a swallow problem, but eventually people get kind of over this initial crisis, and they're kind of getting back home or into the community, and life goes on. And they have to address issues, and should address issues maybe they've never addressed before, like, am I really healthy? You know, should I continue to be 30 pounds overweight now that I have this paralysis? Am I, you know, using some substance that may be preventing me from doing better? Tobacco, alcohol, and so on. So I try to encourage patients to take a more holistic look at what they're doing. Recently in the news has been a center that works with people with paraplegia and quadriplegia from spinal cord injury, and they're demonstrating how much better these people get. And they're in their clinic for about 6 hours a day doing exercises. And I think to myself, gosh, if I was doing exercise for 6 hours a day, I think I'd be doing better too.
Sure.
And the point is that, and I tell my patients sometimes, let's not make a career out of being disabled. Let's get as healthy as we can and move on with our lives and go back to school and make friends and entertain, and let's try to have this be a not the focus of the future, but something that we deal with and incorporate into our lives. Let's just be healthy and get exercise and accept, you know, a certain amount of acceptance is needed for who you are now. You're not exactly like you were before. Change is part of life. Sometimes it's abrupt and cataclysmic, but in the core, you're still the same person, and you know, things change and we move forward. And so I think, you know, mental health is a critical issue. It's under-addressed in the medical model. It's under-addressed in the community.
Does insurance coverage impact decisions with regard to whether treatment will be inpatient or outpatient? In general, I won't ask you specifically at your institution, but in general, well, is that part of the formula that's considered?
It has some effect. I think we can't deny that. You know, we try to get as much as we can for everyone, really. We also try to be responsible and fair. I think that I would never ask for time in the hospital that is not warranted or needed. I think that probably even a bigger issue than inpatient is what's going to be funded for outpatients. Because if we need to continue the rehabilitation process over many, many months, or perhaps years, and the insurance company wants us to wind it up in 2 months, how are we going to fill the gap there?
Sort of person that you end up with as a patient, the severity of their injury may be determined, at least in part, by what happens in the trauma center. How important is that very, very early care for determining sort of the sort of case you end up with?
The early care is extremely important. The management of pressures, both blood pressures and pressures within the brain itself. Much of the damage that occurs after a brain injury is after the initial insult. There may be a relatively minor insult to the brain, which causes then severe swelling, which causes a crush injury within the skull itself, so the brain swells so excessively that it then damages itself. These are the kind of things that can be prevented with aggressive early intervention.
We have a number of brain injury survivors in the audience today, and I'd like to see if they have any questions for you.
Okay.
My question is, why do so many doctors and professionals say that rehab doesn't matter? For me, because I finally did get, well, at least 7 months of rehab after my brainstem hemorrhage, rehab was for me and my spirit like a glass of lemonade for a weary traveler. It helped to restore my quality of life and my self-dignity. And yet so many doctors want to say it doesn't matter.
Well, of course, I'm not one of the physicians that would say that. And I think the only way I can really answer that is that you can know a tremendous amount about something and still be ignorant about other things. And, you know, unfortunately, sometimes our specialization and training causes us to focus in another area. We may find ourselves overlapping with another area. But I do think that in general the medical community is more enlightened today than they were 20 years ago, and more knowledgeable about the benefits of rehabilitation.
You talked about adapt and restore, and the glasses I'm wearing are an attempt to adapt to the bright lights in this room that I'm sensitive to. And the restoration I'm finding through vision therapy. I was told by a doctor, a physiatrist, some years ago that there was no benefit in vision therapy.
After a brain injury, oftentimes the two eyes don't move with great accuracy, the accuracy that they should have. There's a little lagging in one eye or another, and that causes the images obviously not to be in sync and for there to be blurriness. And this can even be an intermittent problem. So at one time of the day a person may see well, and as they become more fatigued they may have their vision degrade. Very difficult to assess, really can only be assessed by someone who has specialty training in this area and some of the tools to do that. It is a very important area, and it's an area of, that can cause significant disability that can be treated. So I'm glad you're looking into it.
How do you like to be approached if a family has a set of concerns about the care that their loved one is receiving?
I think the critical piece is getting them to come forward, having them come forward. The worst thing for me as a physician is to find out that someone was unhappy and I didn't know it, that there was some problem and I never found out. So I think that the real key is to come forward and raise the issues. And I don't think it's, for me, so much of an issue of how they do it. I understand when a family member is distraught, a parent, a loved one, and they don't like the way something is happening. So I've never been offended by a patient, no matter how angry or aggressive they may be, because I know that doesn't happen for no reason, and I think it's my place to kind of roll with the punches, get to the bottom of what needs to be changed, and then make sure that gets done.
Is recovery from a brain injury mainly a function of helping the existing brain cells to function fully, or is the brain capable of growing new brain cells and creating new pathways?
I was taught that the number of neurons in your body are counted, so to speak. You're born with a certain number, you may lose some along the way, you'll never make any new ones. And this has been the traditional thinking for 100 years. In the last couple of years, some scientists right here within a few blocks of where we're sitting right now, Fred Gage and his associates, found that an area in the brain that's responsible for storing memories does reproduce new neurons. And their first patient they tested this on was a woman who had a terminal cancer, and she agreed to donate her body, and she it's a harmless marker that she ingested, and they looked at her brain after she died and found that in her brain, these cells in this specialized area of the brain had been reproducing. Now they've gone on and done also a lot of, even prior to this, did some very interesting animal studies, some involving mice. And one of the things they found with mice is that they also produce these, reproduce new brain cells. And they looked at mice in a very sterile environment where there was really nothing very interesting going on, and they looked at mice that had a very enriched environment with wheels they could run in and things they could play with. And the mice in the enriched environment had a much greater, maybe five-fold greater production of new brain cells than did the mice in the sterile environment. That has some important implications for, I think, even rehabilitation. The brain does not go through these plastic changes unless it's challenged and unless there's an environment that is conducive or requires that this occur.
What do you think the promise of stem cell research might have for rehabilitation?
It's almost unlimited. We know, and again in the news within the last week, what we're demonstrating is that stem cells will implant in injured areas of the brain. Even if you just put them in the circulation, they'll find their way to injured areas in the brain or spinal cord. They'll implant there and they'll grow. And there's evidence to demonstrate in some animal studies that these become functioning neurons. Some of them become assistive, and they allow other neurons that could not function to start functioning. All that. And so the stem cell research is, it's absolutely critical to advancing the treatment of problems like brain injury, stroke, and spinal cord injury.
With regard to stem cells, is there an issue of rejection, the body rejecting stem cells from another host?
Well, interestingly, these stem cells are very well accepted, and they don't have the antigenic qualities that other tissues seem to have. So that is not something that's going to stop this from moving forward and being useful. Rejection does not appear to be an issue.
Thank you very much for being here today and sharing the information with us. And so let's give Dr. Stenehjem a round of applause. Thank you for joining us today. If you would like more information, please click to our website at www.sdbif.org or call us at 619-294-6541.